to class 1B, as you can see here, they are mainly, or one important indication for their use is they act selectively in ischemic ventricular tissue to promote conduction and block re-entry. In general, all sodium channel blockers are preferably used to treat re-entry, in addition to their effect on the SA node with regards to decreasing automaticity. But with regards to ischemic ventricular tissue, and this is a special category regarding 1B, because in the case where we have ischemic tissue, most of the sodium channels will be in an inactivated state. And in general, class 1B drugs have higher affinity for the inactivated states. That's why they are preferred to be used for this kind of drug. With regards to the different states of sodium channel, it's important to differentiate the different states, resting versus activated versus inactivated. And we said, in general, when we talk about antiarrhythmic agents, they have higher affinity for either the activated or the inactivated states. And this explains why the sodium channel blockers are used to treat conditions of cardiac arrhythmias, where we have higher rate of depolarization, and this occurs when we have an activated or an inactivated channel rather than having a resting channel. Okay? So this is one important note. So the next group, we talked about these drugs?
Yeah.
Yes. We reached here? Yes. So class 1C drug, a difference between class 1C, class 1A and B, here their effect on the action potential duration. Well, if you look at different books, رح تلاحظوا إنه هذا الإفكت شوية it's different. But in general, for categorizing them, 1A, what does it do? It prolongs the action potential duration. B, it decreases the action, shortens the action potential duration. Class 1C, it doesn't have a lot of effect, even though it's been noted that it can increase the QRS interval. So it's شوي questionable هذا الeffect, but what we want to talk, the effect of it on the action potential duration is minimal. Now we have one drug here, اللي هو flecainide. Flecainide, it is a blocker of sodium channel, but also it can block potassium channel as well. With regards to other effects, it has negative inotropic effect, so it's going to decrease the firing of the heart. We all know the difference between inotropic, chronotropic, and donotropic or dromotropic effect. So it is yet pro-arrhythmic agent, so it can stimulate ventricular arrhythmias. When do we use it? It's mainly effective in the treatment of supraventricular arrhythmias, especially in normal hearts. In addition to its effect on the SA node and the AV node, it can affect it also. It can cause marked slowing of the conduction velocity. We said it has little change on the action potential duration or minimal effect, let's say. And we use it also in resistant life-threatening ventricular arrhythmia. Now, what do I mean by life-threatening ventricular arrhythmia? Or what do I mean by resistant? Resistant that did not respond to other treatment modalities. We're going to talk about some drugs that are preferable for use for the life-threatening ventricular arrhythmia. If the patient did not respond to these agents, then we can revert to flecainamide. Because as we said previously, it is preferred to use this drug in the case of supraventricular arrhythmia. Toxicity, as with all other antiarrhythmic agents, it's pro-arrhythmic. Other side effects, it causes blurred vision, central nervous system side effect, and also it can predispose to fatal ventricular arrhythmias. فبالتالي احنا ما بنستعمله as the number one choice for the treatment of ventricular arrhythmia. No, it is only reserved for resistant states. Of course, we have to monitor the patient, keep him under monitoring to check for ECG changes, elongation of QT interval, to make sure we don't predispose another attack of arrhythmia during the use of this drug. Another drug, propranolol, propafenone. Propafenone, in addition to being a sodium channel blocker, it also has beta blocking capabilities and calcium blocking capability. It does not have a lot of effect though on the QT interval. But we don't worry too much about Rosali pointing. The main use is for supraventricular arrhythmia. You're going to note that most of the drugs that block the sodium channels are mainly used for atrial or supraventricular arrhythmia. Now, side effects, there are minimal. It can cause metallic taste, يعني الواحد بصير يحس طعم المعدنية بتمه. It can cause constipation, and probably the constipation is due to its effect on calcium channels. And of course, most of these drugs are pro-arrhythmic, so it can cause arrhythmia as well. Now we're going to move on to the second class. We said the second class اللي هم beta blockers, or the drugs that inhibit the sympathetic nervous system. So the first drug we're going to talk about is propranolol. So we've learned about propranolol last year. And again, I'm going to re-emphasize, please go back to your notes about the autonomic nervous system pharmacology, because we will rely on these notes extensively when we especially talk about antihypertensive drugs, okay? So what is propranolol? Who can remind me? Excellent, it's a beta blocker. What kind of beta?
Non-selective.
It's a non-selective. So let's try to remember the different receptors, the adrenergic receptors. We have. So let's talk about adrenergic. We have two kinds, general kinds, alpha and beta. And for beta, what are they?
Beta 1 and beta 2.
So we have beta 1 and beta 2. Beta 1 is in the heart, and beta 2 is mainly in the bronchial smooth muscles. Also, it's present elsewhere in the body. For example, on skeletal muscles, in the vasculature of skeletal muscles, and in the liver. There's a lot of places, but if we're just trying to differentiate with regards to propranolol, what would we expect the effect of it on the heart to be? We're going to be focusing on the beta 1 effect. So, according to what we know, we're going to reduce the activation of the sympathetic nervous system to the beta 1 receptor, thus causing reduction of the contraction and rate of the heart. In addition to that, it's going to also affect the conduction of the heart. All of these effects are through modulating or blocking beta 1 receptor. Now, in addition to its ability to block beta receptor, it has membrane stabilization effect. And some drugs have intrinsic sympathomimic activity. كثير مرات you're going to note that this concept or term is written as ISA. So ISA means intrinsic sympathomimic activity. What do I mean by that? Even though this drug is a blocker, it can sometimes activate other kind of receptor. For example, it can activate the alpha adrenergic receptor. So we're going to note some differential effects on the different tissues. So what would be the effect on the heart? We said it's going to be decreased in automaticity or conduction. So the cardiac effect, and these are due to blocking the effect of catecholamine on automaticity, especially the SA node, and this will decrease, of course, the heart rate. Also, it's going to affect the AV conduction, and it will elongate the refractory period. So what are the effects of the ECG effect? They are similar to quinidine. In addition to that, it causes conduction velocity depression, or decrease with conduction velocity. Now, because we know what is beta 1, or propranolol, sorry, what is propranolol doing in the heart, it's blocking the beta 1 receptors there. We can anticipate the side effect of it, or the contraindication of it. So what would be the effects of propranolol elsewhere? Excellent. So a contraindication of propranolol is bronchial asthma. Why is that? Yes, because it is non-selective, so we have the beta 1 adrenergic receptor, and I want you always to try to remember اللي هو fight or flight response, and this will help you remember what are the effects of the sympathetic nervous system. For the bronchi, when I'm in a fight or flight response, my bronchi need to dilate to allow more oxygen to enter the lung to get diffused to the body. So if I oppose that effect, it is represented by the beta-2 adrenergic receptor by the use of propranolol. I'm going to have bronchoconstriction. That's why we say propranolol is contraindicated in patients who have asthma, patients who have COPD, chronic obstructive pulmonary diseases. So if we just remember what is the mechanism of action of drug, we're going to understand the adverse effects. So adverse effects, here, it causes negative inotropic action of the heart, and while it might be beneficial in tachycardia, we don't want to lower it too much. It can cause bronchospasm, as you can see here. Now, what are the effects or the uses of beta-adrenergic blockers? It's used mainly for atrial tachycardia, so different kinds of atrial tachycardia, for example, paroxysmal atrial tachycardia. It can be used to treat tachycardia or arrhythmias that is associated with the use of a certain group of drugs called halogenated hydrocarbons or hydrocarbon anesthetics, trial hydrocarbon anesthetics. If we have a patient undergoing general anesthesia, there are different kinds of general anesthetics that we will be discussing in the second semester of the central nervous system. PND IV, general anesthetics, inhalational, if you've ever seen a stage. So these inhalational ones, some of the drugs are considered a chemical group called halogenated hydrocarbons. From the side effects of these halogenated hydrocarbons, they can precipitate cardiac arrhythmias. So propranolol is a safe drug to be used to prevent or to treat the occurrence of these kind of side effects associated with general anesthetic agents. In addition to that, they can be used to treat arrhythmias associated with tricyclic antidepressants or L-DOPA. Also, in the condition of pheochromocytoma, you've learned about it last year, right? Also, it can be associated with cardiac arrhythmias. So, because of high levels of catecholamine, so using propranolol, because it is non-selective, it will help treat most of the signs and symptoms associated with pheochromocytoma, especially in relation to the cardiac muscle or to the cardiac arrhythmias. هلا نكمل بالadverse effect. This drug, if you remember, it crosses the central nervous system, so it can be associated with depression or nightmares. And some people, when they start using propranolol, they have these nightmares or consider some psychotic side effects. Another important side effect اللي هو rebound increase insensitivity to beta-adrenergic agonists on withdrawal. What do I mean by that? And this is something we explained.
لما الواحد ياخذ دواء لفترة طويلة
ممتاز.
recommendation للريسبتور increased expression لما توقف الدواء فجأة بصير انه increased sensitivity بصير response كثير
Excellent. شو اسمه؟ Grand. زي ما حكت زميلتكم Grand, and this is something we talked about last year with dynamics when we talked about receptor upregulation. And we talked about something called receptor downregulation, but here it's mainly about receptor upregulation. When does receptor upregulation happen? It's when we have a continuous blocking of something that the body is usually used to. So we said we have the heart, we have a certain number of beta-adrenergic receptors in the heart, and usually we have adrenaline or adrenaline that's activating these receptors to give me a certain amount of signal. Now, once I start using a blocker, the signal will be reduced because let's say half of these receptors are going to be blocked, so I'm getting half of the signal. So the body or the heart is not used to that. So what the cell does, it says, I want to bring back the signal back to normal. So it increases the synthesis of receptors, and we call that upregulation of receptors. So I have a higher number of receptors on the cell surface now. Now, with a higher number of receptors and the presence of a blocker and the presence of the agonist, endogenous agonist, we're still in an okay condition. We are in homeostasis, let's say. We balance out everything. But the problem would be if we suddenly withdraw a beta blocker, if we suddenly withdraw this drug, and we have a higher number of receptors, and it's explained here as a higher sensitivity, this means that we don't have the blocker anymore, but yet we have a lot of adrenaline circulating around with a higher number of receptors. It's going to activate the heart more. So overactivation or overstimulation of the heart will cause an arrhythmia. So this can predispose to an arrhythmia or even myocardial infarction. Okay? So it's very imperative, if we have a patient taking a beta blocker, such as propranolol, is to taper down the dose if I decide to stop this use. يعني إذا المريض بده يوقف هذا الدواء طبعا بناء على نصيحة الطبيب ببلش يخفف تدريجيا. مثلا كان ياخذ 100 milligram, we tell him, okay, for 4 days take 50, another 4 days take 25, then 10. So the body will re-establish the levels of the receptors back to normal. Okay, and this is very important with regards to all uses of beta adrenergic receptor blockers. Another adverse effect, مع إنه إحنا مش حكينا, it is one of the electrophysiological effects اللي هو it blocks the conduction. I want to slow the conductions in certain kinds of arrhythmia, but I don't want to slow it too much. So in certain cardiac condition, also with the use of other drugs that block the conduction, we want to be careful. So it's contraindicated to administer 2 drugs that slow the conduction or cause an AV block together. Example of these drugs, we have some of the calcium channel blockers we're going to talk about later today. So this is an adverse effect or contraindication for the use of beta blockers. Now, another drug called carvedilol. Carvedilol has a special characteristic. شو هو? Excellent. It's an alpha and beta adrenergic receptor blocker. So it is beneficial to be used in heart conditions such as arrhythmia, such as heart failure, but also because it blocks the alpha adrenergic receptor. What other additive value do you think I'm going to get? Excellent. It's going to treat hypertension. It's going to lower the blood pressure. شو كمان حكيت? Inhibits sympathetic. Yeah. So excellent. It's going to also. So we're going to affect another pathway of the sympathomimetic action, which is the alpha adrenergic receptor effect on the vasculature. اللي هم شو الالفا adrenergic receptor بيعملوا بالvasculature? They cause constriction. So if I block that, and this is why I'm telling you to review the autonomic nervous system of sympathetic mainly. Parasympathetic we're not going to go through actually. Why? Because we're going to use the drugs that antagonize the alpha adrenergic receptors to lower the blood pressure. فغالبا المرضى they have multiple pathologies. They can have hypertension in addition to arrhythmias, in addition to heart failure sometimes. So having these polypathologies or multiple diseases, it's preferable to use one agent that can target all of these instead of giving them a polypharmacy, instead of giving them a lot of drugs. Because if we give them a lot of drugs, what would be the problem? Drug-drug interactions. Excellent.
دكتورة؟
Yes.
هلا قصدي بالباروكسيزمال اتريال تاكيكارديا يعني ري انتري سيركس تاكيكارديا نفسها؟
نفسها it's 2 forms of re-entry, so it can be present على AV حكينا عن AV node, or it can be between the atrium and the ventricle. It can be also in the atrium. يعني وهذا المصطلح شوي واسع.
قصدي ايش قصدي بالباروكسيزمال يعني مش نفس الري انتري؟
It is one kind of re-entry is from the
باروكسيزمال بس مش يعني دائما.
اوكي مو عشان هيك قلت لك هو المصطلحات هاي شويه مميعه بين الديفرنت doctors. فهي it is one form, let's say, of supraventricular tachycardia. Okay, and let's keep it as simple as that.
طب ايش معنى باروكسيزمال؟
باروكسيزمال
باروكسيزمال
يعني تروح وتيجي يعني ما بيكون في يعني
متناوبة يعني؟
تروح تيجي بسرعه.
اوكي مراوغه يعني؟
تناوب يعني؟
تناوب. So let's move on to talk about other beta blockers. We have acebutolol, metoprolol, and both of these are beta-1 selective drugs. With regard to acebutolol, there is something special about it I wanted to mention, but it will come up later. But so these are beta-1 selective drugs or beta-1 selective adrenergic antagonists. So we will not worry too much about asthmatic patients as we would with propranolol, a non-selective drug. Another beta-1 selective drug is called ismolol. Ismolol is short-acting, so it's preferred to be used during the operations when I have a patient who is undergoing a certain procedure, for example, a cardiac procedure, and we said surgery can stimulate cardiac arrhythmias to occur. So we give it either prophylactically or in the case of an acute arrhythmia during an operation. Why it is preferred? Because it's short acting, so we can control the level of this drug. And of course, we're going to monitor the patient after the procedure is done. Another class 1 drug, although we're going to see it again in class 3, it was xylitol. Xylitol is a non-selective beta blocker, but also it is a potassium channel blocker. So it's going to be belonging to these two groups. We're going to talk about it more when we talk about class 3 agents. I'm trying to remember the thing I wanted to say about messenger.
هو سالوتول ولا ساتولول؟
Yeah?
هو سالوتول ولا ساتولول؟
Satolol.
During catheter insertion or heart surgery.
Minna. Yeah.
During a surgery or catheter insertion, they are used to prevent acute arrhythmia.
اللي هو اسمه ممكن. هاي من الكتاب صح؟ لا.
I guess you said it because it's
okay.
verified. I
Okay.
guess that's the thing you wanted to say.
Maybe. لا في شيء ثاني with regard to the mechanism, special mechanism, but it's going to come up later. So pardon me for that. بلخبطوهم الأجوبة. I agree with you. يعني خاصة لما يكونوا a lot of the same family. But again, what we want to focus on with regards to the our general knowledge. يعني إحنا بنستخدم basic level of pharmacology or general mechanism of action. What will be the effects, clinical effects with regards to arrhythmia? I want you to know a little bit about the electrophysiology, not the ECG changes, but the general electrophysiological changes, and the prominent side effect, and of course the special uses. Yani this drug is a drug of choice for the treatment, for example, of supraventricular tachycardia or blah blah blah. Okay. Amiodarone is a class 3 drug. What do I mean by class 3? Blocking potassium channel. But even though it only, sorry, it's not only, even though it belongs to the family of potassium channel blockers, it have also class 1 action. It can also block calcium channels. It also blocks alpha and beta receptors. So it has multiple action, but the general category or main mechanism of its action is potassium channel blocker. Why does it have so much different effect? It has some effects on lipid solubility or the membrane permeability, so it can affect multiple channels. When do we use this drug? We use it mainly for life-threatening atrial and ventricular arrhythmias. It can cause slowing of the heart rate. Of course, it's going to slow the AV conduction. مع إنه بيسبب QT interval elongation, بس incidence of torsades de pointe associated with this drug is low. حكينا it blocks the alpha adrenergic receptor, so what would happen to the blood vessels? Vasodilation. So it causes peripheral vasodilation, especially when used IV or at higher doses.
كنت تحكي عن ساتولول إنه ممكن يعمل elongation للأكشن potential duration.
Satolol, حنرجع له احنا in a separate slide and we'll talk about it more. Now, how do we use amiodarone? حكونا mainly it's used to treat acute conditions. So in an acute condition, we give it IV. We start with a high dose, a loading dose of 10 grams, and then we continue with the patient with an oral dose of the drug. The half-life now, it's very long, half-life. So the half-life is between 25 to 110 days. Important thing we want to remember, it is metabolized by cytochrome P450. And I don't go through the different subfamilies of cytochrome P450. I'm going to talk about the general group. Did you learn about these kinetics? 3A4 to D6. Okay. So any drug that's also going to be affecting 3A4 is going to interact with it. For example, we have here digoxin and anticoagulants. They are also an area of drug-drug interaction. What are the toxicities associated with it? It has a special extracardiac toxicity. It can cause lung fibrosis, but only in 1% of the patient, but we want to remember that. Another important side effect, and شوي distinguishing, it's associated with something called blue man syndrome. اللي هو بصير في عندي color discoloration بالskin of the individual. Also, it causes deposits, corneal deposits. فبيعمل different kind of deposits in the skin or in the cornea or mucous membranes. Other side effect, it has central nervous system side effect. It can either cause hypo or hyperthyroidism. يعني how does that relate? يعني كيف احنا مرات كثير بنستغرب when we look at side effects. Sometimes we see constipation in the area. Here we see hypo and hyper. No, it's not. Some patients will represent with this form of side effect. So side effects are reported. We do studies. We give the drug for a big group of patients, and we look how many people represent with this side effect. Now, if I have something about 1%, we have to report it. So 1% of people, let's say, got hypothyroidism. Another group of patients reported hyperthyroidism. So we have to report all of these side effects. Well, not everything is explained by common sense or mechanism of action, but these are things that occur. Of course, it depends on the genetic structure of the patient, other diseases that he has, their susceptibility for this particular condition.
ممكن الايودين اذا كان موجود فيه السبب
إذا كان الأيودين
مش يعني ممكن يكون تركيبة الأميودرون.
I don't really know the structure of it. Does it?
لا أنا بس I'm guessing لأنه كان هايبو.
Let's see if we have the structure here. Few iodine, yes. Yeah. So you are right. That's why it's affecting the thyroid. There is iodine group here on that ring. I have good news for you. هذا مو مطلوب منكم. أول واحد مش مطلوب. It's an old drug. It's not used anymore. بس نحكي عنه شوي ولا نحكي عنه بجوز بالهايبر. It was used as an antihypertensive agent. Brichylidium tosylate. أخذتوا عنه أنتم بالأوتونومي؟
لا.
لأنه شوي confusing.
في اسماء كانت زيها في الجانجليا بلوكرز اشياء.
هلا هو لأنه بيشتغل على الجانجليا أصلا هو it's strange. It is inhibiting the release of norepinephrine, but it can originally stimulate norepinephrine release. Why? It gets reuptaking by the transporter of norepinephrine. It gets accumulated in the vesicles. It's not used as an antihypertensive anymore. There is better drug than this drug, and because it has different effect and it can stimulate initially norepinephrine release, we don't use it a lot. It can be only used in certain cases of arrhythmia, as you can see here. Ventricular fibrillation after failure of cardioversion. Some people go to an operation called cardioversion to treat arrhythmias, and this operation failed. So we can revert to this drug. Or some patients have used lidocaine for the treatment of ventricular fibrillation, and also this drug has failed. So if we have failing of multiple drugs, we can revert to this medication. بس مو مطلوب منكم زي ما حكيت في البداية. Sapolol, it's a beta blocker as we said, but also have class 3 action. It's used for both atrial and ventricular arrhythmias. Because it is a beta blocker, it can cause bradycardia, and it can cause elongation of the QT interval as well. Other side effects it can predispose to, it can cause heart failure as well. So we have to be careful about its use. مع إنه it's a beta blocker, we're going to tell about beta blocker being used for the treatment of heart failure, but because of its effect on conduction, slowing down or causing an AV block, we don't prefer to use it so much for the treatment of certain conditions of heart failure. Ibutylide, this is also a class 3 drug. It slows the cardiac depolarization by working mainly at delayed rectifier potassium channel. Also, it's been shown that it can activate slow inward sodium current. So this is another mechanism of how it can alter membrane potential and causes prolongation of the action potential duration. Now when do we use it? ممكن شوي ما نحكي شباب؟ Maybe هلا it's a little bit too much, but I don't want you to focus too much on IV orally. إلا الأشياء اللي ركزت عليها. I don't think I did for any, but مثلا for this drug, for example, هو مكتوب IV. Butylide is used for the acute conversion of atrial flutter and atrial fibrillation to normal sinus rhythm. يعني مريض عنده an atrial tachycardia or atrial arrhythmia, either in the form of a flutter or fibrillation. حكينا the main difference between flutter and fibrillation اللي هو regularity وشوية السرعة كمان. We noted that the flutter responds better to a butylide than fibrillation, and it makes sense because fibrillation is more serious and less regular. Adverse effect, it causes excessive QT interval prolongation. بالتالي it can predispose to torsade pointer. لأنه بنستعمله IV بهاي acute condition, we have to keep monitoring the patient, especially because we are at the risk of developing of this long QT interval اللي هي torsade pointer. فلازم نضلنا نراقب المريض طول فترة, of course هو موجود بالمستشفى طول فترة administration, and after 4 hours of stopping the medication to make sure that the QT interval returns back to normal before the patient is released back home. Now the fourth group اللي هم class 4 drugs, and these are the calcium channel blockers. هلا calcium channel blockers, we're going to learn about them in a bit actually بحدث ischemic heart disease. We have two groups of calcium channel blockers, the dihydropyridines and the non-dihydropyridines. The ones, the difference between the two, they are different in their chemical structure, that's why they have these different chemical names, is their site of action. So, we have two drugs here, verapamil and diltiazem. They mainly work on cardiac muscle or cardiac myocytes. What about the other drugs? We have nifedipine, amlodipine. They mainly work on vascular smooth muscle cells. So, because we're talking about cardiac arrhythmias, if we want to block the calcium channels, which kind of cells, cardiac cells will be affected? Which one does the depolarization depend on calcium?
Modified ones.
Specialized, excellent. Less a node with AV node. So we're going to be affecting these kind of channels most commonly. Both of these drugs, verapamil and diltiazem, they block the activated and the inactivated L-type calcium channel.
So they decrease conduction.
Yes, they affect the pacemaker cells and the conduction. So the effects are more markedly in the tissue that fire frequently, less completely polarized at rest. فبالتالي هذا حكينا اللي هو selectivity for the state of the channel, because we have, in the case of arrhythmia, the channel is firing more frequently or at a faster rate. So this drug will target these channels rather than the resting channel in a normal heart condition or normal tissue. So what is the use? Mainly it's used for supraventricular tachycardia, so it's used for paroxysmal supraventricular tachycardia. They have also effects on other kind of calcium channel. While they work mainly on the cardiac myocyte, they can have other effects. لأنه calcium channel, L-type calcium channel, where are they present? Also they're present peripherally, with vascular smooth muscle cells. So they will prevent calcium entry to the vascular smooth muscle cell, prevent contraction of these muscles, بالتالي يقللوا vasoconstriction, so they will have vasodilatory effect. Because they affect the AV nodes, they can cause severe AV block in diseased heart. That's why we said we don't combine them with other drugs that can cause an AV block, such as propranolol or beta blockers in general, and even selective beta blockers. So they are relatively safe, and they are used in an array of conditions. So we started here with arrhythmias, so we're going to know that these drugs are used in cardiac arrhythmias. Next topic we're going to move on, they're also used in ischemic heart disease. And where do you think they're going to be used? Yes, they're used also in heart failure, and because of their vasodilatory effect, they can also be used in hypertension. But we prefer to use the drugs that target the vascular smooth muscles more. We're going to talk about later on زي example عليهم nifedipine والamlodipine. So they are relatively safe. They can cause constipation. تلاحظوا كل الكالسيوم channel blockers or any drug that affect calcium channel causes constipation. Late because it's going to affect also the contraction of the GI smooth muscles as well. It can cause gastric discomfort, vertigo, headache, nervousness, and pruritus. They can increase digoxin level as well. Clearly, digoxin is a very dangerous drug, as you can note, and we did not cover it yet. We're going to cover it briefly today. We're going to talk about it more with heart failure. We said this drug, while it's a very old drug, it's very important to know about it. It's used minimally nowadays in certain conditions that is refractory to other treatment, but in some population, it has been used for a long period of time. It might be still be used, so it's very imperative to know about the proper dealing with this drug, especially with regard to its toxicity or with regards to its drug-drug interaction. So, okay, I'll try currently we're not going to have, we have 5 minutes left, right? خلينا ناخذ بريك شوي ونفكر. هلا احنا محاضرة الاسكيميك هارت ديزيز المفروض نص محاضرة اليوم اللي اخذناها، المحاضرة الجاية كلها داخل الامتحان، فالمرة الجاية I will try to finish as much as possible. If not راح اكمل بالمحاضرة الثانية فحيكون كل الاسكيميك هارت ديزيز داخل الامتحان، مش انه تغيبوا عن المحاضرة الأخيرة لو ما كملنا، اوكي؟ لا هي الماتيريال نفسها السلايدات اللي عندكم الماتيريال نفسها بس الوقت اللي عم بقضيه وانا اشرح الماتيريال زاد بجوز اخلص كل المحاضره المره الجايه اوكي
اعطي المحاضرة اليوم زيادة.
نفسها
عندنا
أنا أول ما أخذينها هاي
خلص
أخذينها هاي شيء كنت فاتح السلايد الثانية أخذينها
So هلا هذا الجدول
ماسك شيء ثاني.
Please, I'm going to postpone it for a bit. So it talks about the antidystrythmic drug unclassified in the Vaughan-Williams system. مذكور بعض الأدوية اللي مش تابعة للكلاسيفيكيشن اللي حكينا عنه اللي هم we have atropine, adrenaline, isoprenaline, digoxin, adenosine, calcium chloride, and magnesium chloride. Hello, what I'm going to mention in this table اللي هو atropine. What is atropine? ما الاسم تاعته نبلش Yeah, هو بيشتغل parasympathetic. It's a blocker of the parasympathetic nerve, anticholinergic drug, right? So, what would be the effect of the نحن نبلش أول شيء هيك بالبيس parasympathetic nervous system على الهارت. Bradycardia. So if I antagonize this, I'm gonna reverse the bradycardia. That's why antagonizing the parasympathetic nervous system by the use of atropine is used to treat sinus bradycardia. Another drug called isoprenaline. مين متذكر isoprenaline؟
هذا بيتا بلوكر.
شو هذا؟ بس agonist ولا antagonist? Agonist, yes. So it's an adrenergic agonist. So an adrenergic agonist, what would it do? It's going to increase sympathetic activity. So it's used in certain cases of heart block. And if you remember also, it was used to treat torsades pointed in the emergency treatment. ليه؟ لأنه مرات torsades pointed because of the prolongation بصير عندي AV block. So to بالhospital setting, مش نعطيه للمريض بنروح على البيت. In the hospital setting, we can give him isoprenaline to correct that AV block that happened during the acute condition of torsades pointed. And you can go back to that slide and note that. So what about adrenaline? What is adrenaline? Adrenaline, we all know it. So it's a sympathomimic agent. So when do we use it? We use it when the heart stops completely. So I have an emergency situation that I have a patient that's almost dead. So what I do, I give him an injection of adrenaline to try, if I don't have anything else, or I'm sure that there's nothing else we can do except for trying to resuscitate the heart. So we use epinephrine or adrenaline for the condition of cardiac arrest. هلا إذا عندي مريض during the operation مفتوح قلبه وصار عنده cardiac arrest, we can give him an injection, intracardiac injection of adrenaline during that procedure. Now let's talk about these drugs a little bit in detail. Digoxin, adenosine, calcium chloride and magnesium chloride, but this table summarizes stuff for you. So for example, digoxin, the only indication for it is to treat rapid atrial fibrillation that is not responding to other treatment. Adenosine is a drug used to treat supraventricular tachycardia, and this is the drug of choice to treat supraventricular tachycardia. يعني مع إنه ذكرت كثير من الأدوية اللي هم they manipulate the ion channels, especially sodium ion channels that are used to treat supraventricular tachycardia. Drug of choice is adenosine. Why? Because all the other drugs are pro-arrhythmic. This drug does not interfere with ion channel, so its likelihood to cause cardiac arrhythmia is less. شكلي حبلش أختصر سلايدات كمان. So magnesium main important use for it, and I want you to focus on these. It's effective in the treatment of torsadic faulty patients, even though if magnesium level is normal. We have noted that magnesium levels are important to stabilize the levels of sodium and potassium. So it works on sodium-potassium ATPase channel, sodium channel, and certain potassium channel in addition to calcium channel. It is effective IV in refractory digitalis-induced arrhythmia. What do I mean by that? So digoxin or digitalis can induce arrhythmia. If it did not respond to other treatments, we can go ahead and try magnesium. We give it IV in the emergency setting. Potassium salts. Of course, potassium, احنا بنعرف إنه hypokalemia is one of the important predisposing factors for cardiac arrhythmia. So it's used for different kinds of arrhythmia, especially for digitalis-induced arrhythmia with hypokalemia. We talked about also torsades pointe being supplemented with potassium. Yeah. And especially if it's a condition of hypokalemia. هلا إذا المريض عنده hyperkalemia, of course we don't give potassium salt. هلا digitalis and adenosine. We talked about digoxin being an old-fashioned agent for heart failure and our atrial arrhythmias. It has direct action through inhibition of the potassium-sodium ATPase pump, and we're going to explain this more in heart failure lecture. It has also vagotonic effect. So this is important because it causes enhancement of vagal tone, and this causes withdrawal of the sympathetic nervous system activity. So it's very important that the effects on the cardiac arrhythmias are mainly due to activation of the vagal tone. This occurs through sensitization of the baroreceptor reflexes. When do we use it? It's used to treat ventricular arrhythmia through making the AV node more refractory to the numerous atrial impulses. The adverse effects, it causes arrhythmias. Other side effects causes nausea, blurred vision, and ببين halos.
side effects.
Yes. The other drug, adenosine. What do I want you to know about adenosine? It mainly activates inward rectified potassium current, and it causes inhibition of calcium current. احنا بنعرف شو الادينوسين. Adenosine triphosphate. So it's a natural nucleoside present in the body. It is very short acting, so we use it IV. It causes slowing down of phase 4 depolarization in the SA node. The main important thing I want you to know, it's used to treat supraventricular tachycardia. Now, it can be replaced by verapamil for that purpose as well. One important drug-drug interaction, في drug is called thiophyllin, وفي الكافيين. كلنا بنعرف الكافيين. Both thiophyllin and caffeine, they are adenosine receptor blockers. So if we have a patient taking too much caffeine, so we have a blocking the receptor of adenosine, this will interfere with the action of adenosine. Or if a patient is taking thiophyllin, thiophyllin is one drug that's used to treat asthma condition. So because why is thiophyllin used to treat asthma? Because blocking the adenosine receptor causes bronchodilation. So if I give adenosine, this will cause bronchoconstriction. That's why we're going to know that the side effect of this drug, it can cause chest tightness, in addition to causing flushing in 20% of the population. Other side effects cause headache, hypotension, nausea, and paresthesia. Okay. So how does it work? It works on the adenosine receptor. inhibit adenyl cyclase. حكينا it activates sodium channel. And this is the adverse effect causing hypertension, facial flushing, headache, and bronchoconstriction. And it can cause sometimes possible symptoms of angina because ممكن يعمل slow conduction in AV block. ممكن نعمل شغله واحنا نحكي عنها بالانجينا اكثر اللي هو الcoronary steal phenomena. And we're going to